Hello, everyone, and thank you for joining us today for our webinar of Know Your Rights as a Patient. My name is Nicole Christensen, and I am the president of Care Answered. We will be taking questions in the chat. So if you have any questions or concerns, please write them up because I'd love to get to them. I hope that this will be interactive. I'll pause between the slides if you want to take yourself off mute and ask questions that way as well. Again, and welcome. I'm very excited about this webinar because I believe it has a lot of information that I'm often asked that can be very, very helpful in accessing one's best care. So again, Care Answered. I'm also the author of the book From Crisis to Calm that we'll talk about a little bit later. Some of this information is in there as well. Okay, so let's get to it. Prepared patients equal better outcomes. It is the case as we are, as patients, the number one element of our care, right? We know ourselves. So how can we better prepare ourselves? The first thing I'm going to mention are advanced directives, which those who have gone to any of my webinars probably have heard this enough and hopefully have taken action and convinced others too as well. We'll talk about the healthcare proxy, the POA, the MOLST form, living wills. We'll just touch on them because I'm working a lot with those that are healthcare proxies, being a healthcare proxy partner. And we're going to talk a little bit about the information that needs to be in those forms and, as importantly, the discussions that need to be had as well. And portals and preparedness. So within the patient portal, it is still surprising to me how few people use them as a caregiver as well as a patient. And so there's probably some reasons for that, but we're going to just talk about it. And there's been some new exciting things that we all have access to on our portals. We'll be talking about virtual versus in-person visits, patient portals and notes, and then hospital and insurance, hospitalists versus community doctor, EOB, which is an explanation of benefits versus an actual bill, safe discharge, and rehab and doc visits. So that's just an overall what we'll be discussing. So we'll start with healthcare proxy or an agent, or sometimes they're even called in different states, power of attorney for healthcare. So what it is in general is that a medical decision can be made by this person, this healthcare proxy or agent, if one is incapacitated. So anybody 18 or over should have a healthcare proxy in place. Many of you have probably heard the nightmare stories of a parent who their child is away in college and they have no way of making any decisions for that child because as of 18, they're making decisions on their own. And if there's no healthcare proxy in place, there's nobody to make healthcare decisions if they become incapacitated, even for a short time. So it's very, very important to fill out. This Thanksgiving, when you're around your loved ones, try to sneak that into the conversation as how important it is. But as important as that paper is, you can get online very easily, is the discussion of what can happen. And those things, those answers may change. And that's okay. Hold on, we're just gonna mute. And that's okay. It's the conversations that, if they're continually had, can then be updated. So that paper can be updated. And more importantly, that conversation needs to be clear. What I wanted somebody to do as my healthcare proxy 10 years ago is different from what I would want them to do now. And it's going to be different from what I would want them to do in 10 years. So it's an ongoing conversation. Now, power of attorney. People are often scared of power of attorney. They think that they're giving the rights to somebody else to make all money decisions or financial decisions. Keep in mind that that's only if you are incapacitated, meaning you can't make those decisions. This is so important because of many things, financially, of course, but also remember that healthcare and finances go hand in hand. Healthcare costs money, right? So we want to make sure that we're having these conversations that I mentioned with all of the above people. Oftentimes, the healthcare proxy may not be the same as the power of attorney, same person. So we need to make sure those conversations are happening with all of those folks so that there's not a battle when we're incapacitated. Again, we've heard the horror stories of people that didn't have a healthcare proxy or were saying something different than the healthcare proxy, and then they don't know what they're doing as far as what the person would want. At the end of the day, both of these positions are to make decisions as you, right? They're not making really their own decision. They know what you would want. So therefore, they're working on your behalf. This is not supposed to be anything that's by surprise. It's not necessarily an easy thing to do. It doesn't necessarily go to the person you think loves you the most or who you love the most. It's the person that is very close to you that you trust that can also make those decisions as if they were you. So again, those conversations need to happen. Oftentimes we talk about advanced directives, people talk about living wills. And I work a lot with attorneys that create these forms, which are so helpful. However, they do not really hold much weight when you are in a healthcare institution because it's created by a lawyer. So that's when we talk a little bit more about the MOLST, which is a medically ordered life-sustaining treatment. So again, as the name suggests, it's medically ordered. So therefore, in a healthcare institution, it's going to carry a lot of weight. I am not discouraging at all a living will because it puts it on paper and it's also extremely helpful for your healthcare proxy and power of attorney so that they know and it's on paper. But again, these conversations are fluid. So we want to make sure that we're not just putting it on paper and putting it in a drawer. And that's what happens most of the time, right? They're like, oh, my lawyer made it. It's somewhere for my mom or for my dad or for my spouse. It's a kind of a living document that we need to be talking about all the time or often enough so that we know that we're making the right decisions. And I'm going to talk a little bit about that with some forms that I've worked on with a client about what they wanted. They didn't know what they wanted in those forms, and they were working with a very capable and knowledgeable attorney, but they wanted to know what would this feel like in actually a healthcare setting, and would it cut mustard or would there be some back and forth? So we'll talk about that in a minute. So on to MOLST. The MOLST or POLST, sometimes they're called because they're physician ordered or medically ordered, depending on what state. They follow you wherever you are. And if you're in an institution, a healthcare institution, if you're away on vacation, if you're at home, wherever you are, it follows you. So now bear with me technology-wise, and I'm going to try to pull it up because people often ask me what it looks like. First of all, I want to say that these are conversations that you have with your doctor. And it's if you have Medicare or any insurance, it should be covered, this conversation and this paperwork. So let's try to bring it up. Let's see the power. It worked. Okay, so this is a form. This is for New York, almost form for New York State. Again, other states will still look at this if you were traveling, and still keep it in mind. Now, generally, this most is for folks that have a prognosis of 12 months to live, or more appropriately, if the clinician would not be surprised if in 12 months they had passed away. However, in our current climate, due to COVID, there has been some conversations and filling out of most forms, because if we've learned nothing, is we've learned from this pandemic that we do not know what tomorrow brings. So even if you are relatively healthy, and this is something you'd like to have filled out, talk to your doctor about it, talk to your clinician. Okay, so just to give you basic insight, this is what the form looks like. It'll have resuscitation instructions. It will have consent for resuscitation.
What'd you say?
Let me just put on mute. Okay. So that we can all hear each other. So they'll have that information. They will also see how it says in section C, physician, nurse, practitioner, physician assistant signature. That's the medically ordered portion. Then in D, it says advanced directives, what you have there. And this is, I think, interesting to people. And it starts a conversation. Even if you're not filling out the post, it's a great way to kind of put your thoughts together. So orders for life-sustaining treatment and future hospitalization when the patient has a pulse and the patient is breathing. So it breaks it down: comfort measures only, limited medical interventions, etc. Intubation or mechanical ventilation, that's like breathing tubes or ventilators. A hospitalization or transfer, whether you'd want that. Artificially administered fluids and nutrition. This is a big one that I feel people often don't discuss. If you have strong feelings about that, you should definitely have that conversation with your healthcare proxy, because I've seen in my experience, and I'm sure we can all imagine, saying that we're not going to provide basic sustenance is a hard thing to do when you love somebody, right? So if you have strong feelings about that, you want to make sure, either way, you want to make sure that your healthcare proxy is fully aware of that. And then antibiotics as well, again, something that people don't often think about. And then you'll see in section F, it has a review and renewal of the MOLST form. So again, it's an ongoing conversation. You may change your mind, and that is okay. So now I know there's a lot of words on this screen, and I'm not suggesting that you read them. But I just want to put it in your minds. So this is a healthcare proxy. This is an excerpt from a healthcare proxy form. And it says here, I bolded a bit, that it says, my agent shall have the status, power, authority, and rights and title as my personal representative for all purposes as provided in the Health Insurance Portability and Accountability Act of 1996. Really important to be in there. That's HIPAA. We often hear about it, but so that they can have access to your medical records. Okay, I'm sorry. There's a question here that I want to address. So does a MOLST or DNR or living will have priority over the other document? Okay, so a MOLST has the information. That's an excellent question, Adam. So before we get farther into it, let me say that the MOLST has the most power, if you will, if I can put it that way, which doesn't make a whole heck of a lot of sense, I know. But the MOLST has the most power because it's medically ordered, and the DNR portion is in there. It's already in there. A living will is a legal document. And although it's a legal document, it has less authority because it's not medically ordered. So if you were in the hospital and your healthcare proxy, you didn't have a healthcare proxy, God forbid, right? So, and you had a living will, does anybody know where it is? That's really important to know. Where is that piece of paper that's going to say it? And if your healthcare proxy says something different than your living will, that's hard for, hospitals and medical facilities. That's what they're there to do, to provide medical attention. So when they're having a conflicting information, that's really difficult. So I don't know how they would answer that at each institution, but I will say we don't want to make it harder than it needs to be. So if you have a MOLST, great, that's probably the highest tier. Your healthcare proxy should have as high of a tier, but those conversations should be ongoing. And I'm going to talk a little bit about that, about what the healthcare proxy could say. Thanks for that. So what I was saying was, this is the HIPAA, so you have access to the healthcare information. So this has a lot of information in it, but not what I want to draw your attention to is the specific wishes are set forth in my living will annexed hereto, right? So that means it's on a separate document. And again, healthcare proxy is supposed to be telling on paper that who you've designated as your healthcare proxy and what you would like them to do. So if you know the specifics, I suggest you put it on the healthcare proxy. It could be on the living will too, but also have it on the healthcare proxy. Because again, so many times the living will, nobody knows where it is. It's, they're saying, contact my lawyer. That's really not the way to do it. You really want to be having those conversations and have your healthcare proxy in full understanding and knowledge. So now this is an excerpt from a living will. You'll see here that it says these instructions apply if I am in terminal condition, permanently unconscious, which that language, although seems appropriate, you want to make sure that the language is really clear, because anything permanently is hard to say, right? Or I have irreversible brain damage and will never regain the ability to make decision and express my wishes. Sometimes that's not clear in the medical community. I would dare say most times it isn't. So again, that's why words are great on paper, but also those constant conversations. But this is a living will, as I mentioned before, which is a legal document, and it has all this information on it, but none of this was on the healthcare proxy, and this is for the same person. So again, you want to make sure that those conversations are happening, that are clear as they can be. Again, not all of us know exactly what we want, and that's okay. That's why it's an ongoing conversation. But making sure this information is clear to your healthcare proxy and designating one is vitally important. So, are there any more questions on that? Let me just check the chat. Okay, I think we're good. Okay, so now this is a slide that I loved so much. I lifted it directly from an excellent conference I was at, the Healthcare Advocate X conference for patient advocates, and shifting paradigm. So you can see it's copyrighted there. That's Dr. Sands, who gave a wonderful presentation. And it's the information symmetry, right? Asymmetry. So I've talked about this a lot before as a physician as oracle, right? That they know all and the patient knows nothing. This is not the way to be prepared, and this may not produce the best outcomes. How comfortable is it? It may be comfortable for some of our clinicians because it's something that they were taught, right? Or something that is expected, or what have you, because of historically. But one can also see it as a burden, right? Because nobody knows everything. But I can say for most of us, we are experts in our own, living in our own bodies, right? Nobody else has that expertise. So our information, what we're putting across and how we're participating is pivotal. So what Dr. Sands put forth is information symmetry, a physician as a partner in your care team. And threatening versus liberating, right? You're having these conversations. And also, I would say liberating for the physician as well, or the clinician, because there's no expectation of knowing everything. You can't know everything. So that conversation and getting to know more from their patient is, I would imagine, liberating, although I'm not a doctor. And then a physician as healer. And like Dr. Sand had said, that's the reason most clinicians get into the field, right? To be a healer. And it's you're much more able to do that when you have all the information that you need, not only the knowledge, the biological knowledge and all of the knowledge that one gets from med school, but also of that individual person, that person that's in front of you. So that's what I hope the entire healthcare industry is working towards. But certainly as patients, as people, we can work toward that by being prepared and informed ourselves. Okay, so choosing your clinician. So oftentimes, unfortunately, people don't have primary care physicians, right? They don't have somebody that kind of knows their basics, knows their baseline, somebody that they go to once a year, especially for younger people. It's just not thought of. But I would say that this is so important because that's how we get our baseline. That's how we get comfortable with somebody. They are our primary clinician. So when you're looking for, if it's primary care or it is specialists or what have you, when you're looking, what's important to look at? A lot of people go to, their friends or family had suggested somebody, and that's a great start. And your insurance covers them, also a great start. But remember, it's all about you. So what is important to you? Some of us, it's important that they have say if we're already diagnosed, we want to know how many of their patients have similar diagnoses, or certainly if they're surgeons or treating the diagnoses in some way, how much experience do they have with that specific skill set? Some people, it's important what gender, they just feel more comfortable with whichever gender. Or culture specific. They feel that they want to go to somebody that shares or has knowledge about their culture, or willingness, certainly, to understand their point of view. All of those are questions that you can and should ask. Anything that is important to you that's going to make you more comfortable in that office regarding your care, it should be asked. What options are there for a visit, right? After in this pandemic, in person, virtual, having somebody with you, an advocate, your healthcare proxy, you want to make sure you know that so that, again, you are the most comfortable and you have the support that you need. For some people that are going in person, what COVID precautions are in place? You just want to know what they're doing to make sure that you are being kept safe and healthy. What are the wait times, right? So what are the wait times in the office? Because that can make a break. There are people that have to take buses and trains or have a very long commute to their physician's office, or they have to get an appointment in the middle of the day. They have to take off work. They were hoping to take off a half day. They want to know, how long is the wait? If I already know I'm going to wait so long, then maybe I'm not going to go there, or maybe I make an appointment for a different time. You deserve to know that basic information. Um, then portals, again, we'll talk about that. How can I access my medical records? How can I get them on paper or electronically? That information is key for you to access your best care. And second and third opinions. Absolutely, especially when you have a diagnosis that is chronic or catastrophic, those second and third opinions are necessary. Okay, patient portals, they are essential. Not everybody has access to a portal. They might not have the app. I am not a technology guru, but I know that there are many supports, and I can look into it to make the portals come to you in one form. So we know that sometimes if we're seeing different clinicians from different systems, they have different portals, and that can be aggravating, but it's still information. And then maybe it would be more helpful for you to somehow get that information consolidated. But it is there, and it's for us. So it's a great communication device. Some are better than others. Obviously, different clinicians are better, but oftentimes you can email, make sure your questions are succinct and clear so that you can get the response that you need. There's sometimes that the response or what you need is going to call for another visit, but there's so many times that it's not. And you can utilize that portal to get those questions answered. So that communication is great for your healthcare proxy as well as the patient. You can share it with them. You don't have to give them access to it directly. I know as an advocate, I often don't get direct access to it, but going through it with them has a comfort level, because as I wrote there, knowledge is power, right? If you know, then you can be more aware of the options that are available to you. Again, and then the clinician and patient, it can be direct communication. No waiting 6 months, 3 months for the next visit. Also now, due to a lot of work from advocates, not just patient advocates, but people in healthcare advocacy in general, clinicians' notes are available on these portals. I don't know if you've used them yet or seen them, but I find this very, very exciting. I still feel that you should go to the clinician's office with your list of questions and write down their answers, but having access to those notes just, again, gives you more information, and you can catch things that potentially are wrong, right? There's sometimes information that was unclear to you or you think is wrong, then you can bring it up in that next appointment or communicate directly. It gives you a chance to review those notes, to ask questions, to prep for the next visit. Also, whether it's with that clinician or your next specialist or a different clinician, you have those notes, so it helps you prep. And then you can have your medical records paperless, like through a portal, or not on paper. They can charge up to 75 cents a page generally. That's why the portal is also very helpful, because for some people that's very expensive, depending how big their file is. So that's another thing that you can have. And the information is in one place, as I mentioned, in the portal itself, or potentially you can look into something that kind of combines all the different portals if that's necessary for you. And again, you can still request paper. Either way, you should have this information at the ready.
I'm trying to reach Monique, please.
Hold on one second. If you could just
Sharon
mute
Reichman,
yourself.
EDRC.
Try to mute.
Yes.
Sharon, can you mute yourself?
EDRC.
There we go. Okay. Sorry about that. Okay. So Prepping for the appointment. So now you're here, you know all of this information. What I always suggest is have your 3 top concerns. If you have a laundry list, it's hard to go through all of it. So have your 3 top concerns, and then you can make sure that you get through those, okay? You wanna make sure you're making the most of the little bit of time that you're given with your clinician. So the more prepared you are, as I mentioned before, the better it will be for you to get your needs met. List of medications, always have that with you, which of course includes the medication, the dosage, what the medication is for, when you generally take it, and also include any kind of supplements or vitamins as well. Review medical notes from previous appointments or from previous clinician. We talked about that a little bit. So that better prepares you for the appointment. And Ask Me 3. This is from the foundation, and it's, what is my main problem? I like these 3 because it really just gets at the gist. If one gets nervous within a doctor's appointment, just remember these things. What's my main problem? What do I need to do? And why is it important to me? Because then it just breaks it down for you. Again, you'll be writing all of those answers down so that you can think about it and be able to digest it when you're not in the office. And ask and repeat. Ask as many questions so that you understand everything that went on in that appointment. It is your life. You must ask and then repeat it, what I call talk back. So whatever you heard, repeat in your own words. It helps you. It helps the clinician to understand, oh, I may not have said that in the way that I intended. So you want to make sure that you understand. And by repeating it, then you'll know for certain in that moment that you understand. Okay, these are big questions that I get a lot. Prescription and insurance questions. Okay, so shifting gears a little bit. Insurance. Know before you select your insurance, if you're selecting your insurance, whether it's a Medicare plan or your employer's insurance or private insurance, you want to know information before you select, and certainly before you go into any kind of office, what they're going to cover. So what is in that network? Who's in that network? What is covered? What's the deductible? Basically, is there stuff you have to pay before insurance pays anything? What do you have to pay out of pocket? These seems really basic, but it can be very, very complicated. So in my last webinar, I had Medicare brokers on, and it's a whole world in itself. And I think I have one here today, Al, who I refer to. It's a whole world in itself. And so if you know all of the information that we discussed before, your medications, your doctors, then your health history, it gives you a better understanding of what might work for you in the future. So know all of these things. And prescriptions. So talking to your pharmacist and your doctor. I like to say that pharmacists drugs are their gig, right? So asking your pharmacist questions about the pharmaceuticals that you're getting is important, and that's why they're there. I also suggest you always have your medications come from the same pharmacy. So if there's any issue or question, if it's counterindicated, they'll know. If you have different pharmacists that don't know of the other medications that you're on, things can fall through the cracks. So could insurance cover delivery? Yes. Could it be delivered to you in blister packs? Yes. And it can all be covered. It all depends. But these are options that you have that I know have worked very well for my clients and family and friends. So know that these are available to you. I think I have a question here. Okay, so we'll get to that in just a second. There's a question about patient choice regarding prescriptions. So we'll get to that at the end of this slide. Thank you. Therapies at home. This is a question I get a lot too. So for example, somebody goes to the hospital, they go to a rehab, they're given through the hospital visit, their insurance, the CHA, they will get physical therapy and occupational therapy, let's say. And then that's over. And they're like, I really think I could go farther and get better if I had more. It doesn't have to end there. You can go to your doctor and request a script, and potentially you can have those therapies in your home or out of your home to continue. But that it does need a script, but know that that could be an option for you. Equipment, things like a commode or a shower chair or shower bars or a nebulizer, all of those things. Ask your insurance if they cover it, get the script from the doctor. A lot of people assume that they'll just have to pay out of pocket, go to one of those stores and call it a day. Sometimes people have done that thinking that they had to pay for it because it didn't go through their insurance. It didn't go through their insurance because they didn't have a script. So make sure you're doing all of those things so that you can, get what you need. Explanation of benefits is not a bill. So I see this a lot as well with different people coming to me and clients as well. People get very concerned. They'll get an explanation of benefits and they'll have all these dollar amounts. That doesn't mean it's gone through all of your insurance. That doesn't mean it's the bill. Generally, don't get nervous until you actually get a bill from that clinician or institution. You can certainly, it may prompt you to ask questions, but I don't want you to think, oh my gosh, this means I have to pay for the rest of this, because that could not, it's possible that that's not the case. And oftentimes is not the case. And insurance as advocate, always ask. So for many people, that sounds counterintuitive. How can insurance be my advocate? But I'll give you an example of a client issue that was most recent. So they had pretty bad bed sores and they needed what they call a wound vac. And so they were able to receive it. It was covered by Medicare. And they were supposed to have it for, a few months. They thought that they could really get more use out of it. And so they said, yeah, let's continue having it, right, to the company that supplied this vac and also the supplies that came with it. They had no idea that it wouldn't be covered. There was no reason for them to think so. So they got it for a longer period of time. And then they got a letter from Medicare saying they weren't going to cover it any longer. And so they were disappointed, but what was most remarkable is that they're not going to cover it and they haven't covered it for the last 6 months. And so what we did was we got in touch with their Medicare provider and they found that we won't cover it, but it is not your fault because there was no way for you to know that it was no longer being covered because the company itself didn't notify you. So now it's up to the company and Medicare, but it has nothing to do with my client. It's not a bill that they will have to pay. And there's many circumstances like that in which even a clinician or healthcare facility has requested out of pocket money that when they called their insurance company that wasn't the case, and they'll step in for you in that case. So always ask. Okay, now, okay, so let's go back to the question. Adam, you had a question.
Yeah, thank you, Nicole. I had a client who was in the hospital receiving IV antibiotics.
Mm-hmm.
As it turns out, that specific prescription was very expensive. They were looking to be discharged to a skilled nursing facility, subacute or rehab, and were declined because they needed to maintain an additional 2 weeks of that IV antibiotic. And that specific IV antibiotic was very expensive. This rehab facility was unable to take that into, or was unable to accommodate
that,
because of
right.
yeah. So the family, as a result, wound up staying in the hospital for an extra 2 weeks. Did they have a right? Could they have consulted with their physician and said, hey, listen, let's figure out a different antibiotic, one that is less expensive so I can go to rehab as opposed to staying in the hospital?
Right. That's a great question. So we always have a right to ask. My guess is that they didn't know. So that's a really good question, because when we're sick, right, we're not, and we're getting antibiotics. We're not questioning how much the antibiotics are, right? That we're in a hospital. That is a really unfortunate incident. The only thing that I can say from my experience, which it wasn't an antibiotic, but it was a prescription drug, I had to actually get it, and it was a very expensive drug that they needed, and they had to go into rehab, that I had to go to the insurance company and to the provider of that, their drug company, if you will, that was under their insurance, to get it. So other than that, kind of when you're in the thick of it, one question I might have asked is to say, okay, I'm on these IV drugs. Is there a reason that you selected this one? Is there any way to change it from the formula that we have now that will not be detrimental to me? If it is detrimental to me, what are the ways it could be? And then they can have more information to make that choice. But that is really difficult because they already had them over a barrel, if you will,
Right.
because they were already taking it.
Nicole, can I interject?
Absolutely.
Hi, everyone.
Hi, Jocelyn.
I worked in infusion, so I can answer that question for you also.
Sure, absolutely.
So with IV therapy at in the hospital, and then you come home, it really depends on what they're treating, and that's how they decide what the drug is going to be. So if you're getting IV therapy, that means that this infection that you have is much bigger than you would get if you were just taking pills. So they're trying to treat it a different way. That means it's it could be a problematic infection, because you never just go automatically to IV therapy because it could be a longer form. It's more invasive because you have to get a PICC line, or if you have a port, whatever it may be, to get it in. And then like this patient, you said had to go to the rehab. A lot of rehabs do not know how to take care of a PICC line. So that's another issue if it's an IV antibiotic, and some of them have to be in a PICC line, which is done under, and it goes into a vein that goes all the way up to your heart. Or if it's an IV, they can handle it, but they have to know they have to take it off. So there's a lot of factors, but it should always, we've had patients that's supposed to go home on IV or say to go to a rehab, or come out of a rehab, but it's considered high level nursing skill. So not every nurse knows how to do a PICC line, not every nurse has to change a PICC line, how to flush it. So that's why a lot of times you'll see a rehab not take a patient that's on IV therapy unless they get it inside the rehab.
The rehab itself, right?
Yeah. And at that, I've had patients be discharged because of the IV therapy, because their nurses were not proficient on taking care of a port or a PICC line, and then they came to us. But patients always told me in the years I worked in IV therapy, you should always ask, because sometimes it's just a broader spectrum of a antibiotic. Same thing like when you get a Z-Pak. Doctors prescribe that so quick, and some nurses would tell you, you don't want a Z-Pak at the beginning of a cold season, because then the next cold you get, there's nothing you can take for it, because it's a broad spectrum antibiotic. So it's all about asking the right questions and being an advocate to say, what are my options here? This is what I need, and I don't want to keep you in the hospital. I can't say what they do now because I'm not in that space anymore, but I know IV therapy at home is up from my former colleagues because of the pandemic. So
Yeah.
it's a lot of questions to be asked to see, because no one wants to be in a hospital or a facility if they don't have to. And I could be in the comfort of my own home. But IV
Thank
therapy
you.
at home is a big thing.
Thank you, Jocelyn.
You're
Yeah.
welcome.
Yeah. I think it's all about, thank you very much, Jocelyn, is asking the questions. But it is unfortunate because once you're already in it, it's hard to
Mhm.
ask those questions. It's knowing the questions to ask beforehand. Thank you for that question. And thank you, Jocelyn. Okay, so going right into hospitals, that was a great segue. Hospitals and your rights, right? So there's a patient bill of rights that we all get when we enter the hospital. And the reality is that nobody reads it because they're sick, and their loved ones don't read it because they're too worried about everything else. But if we can get this out to our friends and loved ones and clients and residents, and to all patients, that they have these rights, then again, Care Answered's mission is also to empower, right? So if we can be empowered with this information, then we'll feel more empowered to ask those questions, like you just mentioned. So I just highlighted some of the things that come up most often, even in just calls to Care Answered. If for any reason you do not understand or you need help, the hospital must provide assistance, including an interpreter. So whatever the reason that you don't understand, you need help, they're required to give you that help. Be informed of the name and position of the doctor who will be in charge of your care at the hospital. How many times do we have instances where I was like, nobody gave me their name, or it wasn't as clear and they're going through things and they're upset for their loved one that they didn't get it. So remembering and that you have the right to that. Know the names, positions, and functions of any hospital staff involved in your care, and refuse their treatment, examination, or observation. Participate in all decisions about your treatment and discharge from the hospital. That's huge. The hospital must provide you with a written discharge plan and written description of how you can appeal your discharge. So a written discharge plan, I also then link that directly to if for any reason you don't understand, right? So it's great that it's written, but if it's not clear to you, that's not enough. You must be able to understand it. Review your medical record without charge. We talked a little bit about that in regard to portals. Obtain a copy of your medical record from the hospital. They can charge a reasonable fee, and cannot be denied a copy solely because you can't afford to pay. So just some of the really important things in the patient's bill of rights. Obviously, it's much longer than that, and we have many, many rights. So just know that and share that with people. So healthcare access and rights. So discharge planning, right? It starts at admission. I say it every time. As soon as they're admitted, we're talking about discharge, what we need to do. So here is a technological breakthrough due to the pandemic, right? So we have access to virtual visits. So I haven't had it yet, but I'm excited about the possibility of one being in the hospital or rehab. And I always say to communicate with your community clinician to let them know so that they can be part of it, even if don't have rights in the hospital, meaning they can't go there. But the idea that you could potentially have a virtual visit with your community clinician while you're in the hospital, I think that is super exciting. I don't know how it will work with a primary care, but I know that pre-COVID, I would have clients in the hospital or rehab that I was advocating for, mostly rehab in this case, in a rehab advocating for, and they needed to see a specialist that wasn't going to be there, and they had their own specialist, or they wanted to see one in the community. So again, rehabs aren't jails. You can go to a specialist in the community. But for some people, that's really difficult because, for example, they could have an IV or something like that. So wouldn't it be wonderful if we could have those same visits if they're going to be helpful in a virtual way? So I think that opens up some opportunities. Medications, equipment, practice on equipment, and appointments determined before discharge. So this goes with the discharge plan that I mentioned. So many times people call me in an emergency. If they're working with me, of course, I always make sure that everything is done, but they don't have the medication for home. They're being discharged and they're like, oh, we called it in. That's not good enough. We called it in because we need to make sure that it's actually there and that they can pick it up. Because there's some people that are discharged that have no access to get to their usual pharmacy. So making sure that you have medications on hand, whatever equipment, you don't want to be figuring that out once you're already home. You want to make sure that equipment in some way is either in your home or will be delivered to your home, something before you get there. And then if there's equipment that you're not used to using, practice on the equipment. So them give you a piece of equipment from rehab that your caregiver can help you with, or your healthcare proxy or a loved one, so that you make sure that those that are helping you actually understand how to use it, or you yourself know how to use it. And whatever appointments that you need, start setting them up on the day of your discharge before you even leave, because that follow-up is also key. Care plan or discharge meeting with an advocate. Have somebody there. So many people call me and I said, oh, did you have the care plan meeting yet for new clients or would-be prospective clients? And they're like, a what? And then I explained to them what it is. It's when everybody on the care team at the rehab is there and they're going through, what the needs are. And maybe they had one and they didn't know it was a care plan meeting, and they also didn't know that they could speak up and say anything. So having those meetings with an advocate or your healthcare proxy is really important, because then those questions that you have can get answered. And then palliative care, hospice care, healthcare proxy, and advocate. I mention this because it comes up a lot. People are confused, sometimes because they're in the thick of it, right? They are emotional. It's a difficult topic for a lot of people to discuss, but your healthcare proxy should be in that conversation in regard to palliative care or hospice care, which are two different things. So I can do a whole webinar on that, and I have, but just basically with palliative care, that it doesn't mean that you're not receiving treatment for whatever your diagnosis is, but it is focusing on keeping you comfortable. Okay, so oftentimes people ask, so can I have a palliative care doctor? And the answer is yes. They can, there are some, but it's hard to find, to be honest, that come to your home and provide all sorts of different therapies. There are doctors, massage therapists, all sorts of different things that you can access. But oftentimes it's hard to find them. The palliative care as a concept is fabulous, but unfortunately, sometimes it's hard to actually find the providers depending on where you're located. And they do especially good job in oncology to have that palliative. For other diagnoses, it's sometimes more difficult. Hospice care is generally put into view when there's a prognosis of 6 months or less. Now, you can get on and off hospice. You can graduate off to hospice. Nobody has a crystal ball. But it is very thorough in that it can help not only the patient, but their family, providing social workers, a nurse, a doctor that's dedicated to hospice for you. However, one misconception, unfortunately, is that there are tons of hospice units in rehabs and hospitals. There aren't. Hospice, when you're talking about at a healthcare facility, is generally for very much end of life, meaning a prognosis of weeks or days. So that is actually really hard to get. The other thing, though, is hospice at home, which is very helpful, and not enough people, I believe, utilize it or take advantage of it. And it's generally covered by your insurance. Because again, it has that comfort care. There won't be treatment, but it will be things that will make you comfortable, and then you can be at home if that's what you so desire. That, however, doesn't come with unlimited home care. Sometimes people think, okay, I'm on hospice and I'll get round the clock aides in the home. That's generally not the case. They offer some kind of assistance, but other than that, you'll generally have to get more assistance if round the clock is what the person wants. That healthcare proxy, again, I mentioned that because they should be part of that conversation, that ongoing conversation. And I say an advocate because oftentimes I'm explaining to folks with that care team what that means and what managing expectations and making sure everything is clearly understood, and advocating in whatever way is necessary. All right, so we covered it. I'm sorry, I'm a little over, but we had such great questions and great answers too. So this is my contact information, and I would invite you, if you have a few minutes, to share your story or something that you think might be helpful for everyone else to hear about. Anybody, any takers? All right. Well, I thank you all for being here. I appreciate your taking part, and we'll see you next time. And have a happy Thanksgiving.
Thank you, Nicole. Bye-bye.
Bye-bye. Take care.
Thank you. You
Thank
too.
you,
Bye.
Jessamine. Bye-bye.